So we have 3 sets of hospitals that will be part of the group 1 presentation. We have McMaster Medical Center, we have North York General Hospital, and William Osler Health System. I will be introducing the McMaster Medical Center, Hamilton. We have with us today Krista Bennington, who is the clinical manager of hematology, oncology, the medical daycare, and palliative care. We also have Alistair Stewart, who is a nurse practitioner, and both of them will present on how McMaster Medical Center in Hamilton, Ontario is improving the quality of sickle cell disease care in their hospital. Welcome.
Thank you. Good morning. And Lanre, can you see the correct slide that I have there?
Yes.
Okay. Good morning, everyone. So thank you for having us as we represent McMaster Children's Hospital and Medical Center in our pediatric and adult hemoglobinopathy program, which hopefully, as you know, includes our sickle cell program here at McMaster.
So good morning, everyone. I'm Alyssa Stewart. I'm a nurse practitioner with the hemoglobinopathy program. I've been at McMaster Children's Hospital for the past 1.5, going on 2 years. During my first year here, my role was to provide outpatient care in various pediatric hematology and oncology clinics, including the hemoglobinopathy clinic. My role has evolved since early this year to focus exclusively on hemoglobinopathy patients.
And as Lanre mentioned, my name is Krista Bennington, and I'm a registered nurse and the clinical manager in a number of our inpatient and outpatient areas. And so in both our outpatient clinic and inpatient wards, our team provides care to patients with sickle cell disease. And while my role includes a number of different things, overall, I summarize my role as really focusing on providing support to staff to have what they need to be able to care well for our patients and families. So we've been invited here today by Lanre and SCAGO to share together and answer the question, how are we improving the care of sickle cell disease in our hospital? We're really grateful for this opportunity to share from our experiences at McMaster and also to learn from our colleagues and patients and advocates across the province, and hopefully we can collaborate and grow more together. Before we get started, it's important to note that we have a unique program here at McMaster. And so even though we are officially called a children's hospital, our outpatient hemoglobinopathy or sickle cell clinic is a joint program where we have both adult and pediatric physicians, an RN, NP, social worker, and others who care for both pediatric and adult patients with sickle cell disease in the same clinic space. The one caveat is that if pediatric patients require admission, they are admitted on site at McMaster Children's Hospital, while our adult patients typically go to St. Joseph's Hospital in Hamilton. And so this partnership or system is important in our context as we talk about the care delivery here at MCH. So it might be a bit unique to some of the other hospital experiences. And I know that we will hear later from some of our colleagues at St. Joe's who can share more from their perspective. So just this morning, we'll be speaking more specifically about McMaster Children's Hospital. So while there's lots to talk about, we only have 15 minutes or so to share with you. And so we'll focus on 5 key areas that we've identified that we've found to be important as we really work to improve the care of sickle cell disease in our hospital. So we'll focus on team expansion, virtual care and optimization, transfusion support, pediatric to adult transition, and partner collaboration. So for team expansion, like many centers, at MCH, there's definitely been an increase in our patients with sickle cell disease population in both our pediatric and adult clinics. With newborn screening and population migration, our clinic continues to grow. And it's super important that our team also grows with our patients' needs. So one of the important team members that we've added over the last year or so to help support the clinic is our healthcare aide named Aola. So Aola actually works in our inpatient area. And while we had no funding to actually have a role in our clinic, we've pulled Aola to help in our outpatient clinic on clinic days. On clinic days, Aola helps to room patients. She provides a warm and welcoming environment and really builds relationships with families. She also spends time on non-clinic days doing reminder calls and supporting patients to ensure they're aware of upcoming appointments. And truly, Ayola has added so much to our clinic and our team over the last year. In January of 2020, we added a nurse practitioner who you've already met, Alyssa, to support our sickle cell patient population. So at first, as Alyssa mentioned, she joined only about 1 day a week dedicated to this role and was mixing her role also with some oncology and other hematology outpatient roles. But we really saw the value of her presence on the team. And so in January 2021, Alyssa started working 4 days a week in our clinic and with our sickle cell and hemoglobinopathy population. Alyssa is super passionate about patient care, is dedicated to this important patient population, and we've really seen the value of her role. And she'll share more later about how she's spending her time to really focus this role. Another area that we're working on and that we continue to see opportunity for improvement on is our education for our outpatient and inpatient teams. As we work to provide best care for patients across their whole journey, whether it be inpatient or outpatient. And so when staff join our team, whether that be nurses or social workers or other care professionals, we have training specifically about sickle cell disease. And that training is led by our NP or our RN, Erin. And our goal is to continue to ensure that we have ongoing up-to-date education for all of our providers. And so as we talk about expanding our team, I think it's really important to note that we need financial support to do this. So at present, we have a number of positions that don't have funding. And so we've been just going above budget because we know that there's a need, but we really have been appealing to the ministry for our help. Our team is very lean in size. And while it's a group of amazing, passionate, dedicated, unbelievable professionals, we know that we need to continue to grow so that we can continue to serve patients and families with the best care, not just today, but as we look ahead into the future.
Virtual care and visit optimization. So throughout the pandemic, our program and hospital is not unique in the way providing outpatient care has transformed in terms of prioritizing those patients who need to be seen in person and considering virtual follow-ups where we can limit patient flow in the hospital. That being said, has really highlighted the value and benefits of offering virtual care appointments to our sickle cell population. We have been able to reach patients who have otherwise been lost to follow-up because of the barriers to coming to hospital for routine outpatient care. We have continued to offer virtual follow-up visits from a patient and family-centered approach to reduce some of the burden that comes along with multiple visits to the hospital. So specifically in the pediatric clinic, we have been attempting to alternate telephone and in-person visits. By offering virtual visits, it eliminates some of the financial burden for patients or families when coming to the hospital if it requires them to take a full day off of work, and for pediatric patients by reducing the impact of missing a full day of school. It also eliminates the pressure for some families where transportation may be a barrier to coming to appointments. Specifically for our pediatric sickle cell population, we have been trying to work with families to proactively coordinate tests and other appointments, as well as follow-up blood work. We have been offering Transcranial Doppler Ultrasounds, or also known as TCDs for short, which is a routine test for most of our sickle cell patients. We have been offering these tests on the same day that we run our hemoglobinopathy clinic. This allows the opportunity to coordinate this test with their follow-up clinic visit. We have overcome some of the scheduling challenges by having direct admin support within our department to schedule the TCDs. This has allowed for better coordination and flexibility within the context of limited resources to provide this special test in our center. We are also working on reestablishing our relationship with a pediatric respirologist who has a special interest in sickle cell disease and is involved in the care and management of a subgroup of our sickle cell pediatric patients. We are working to have joint clinic appointments with the respirologist rather than separate clinic visits, again, to reduce the number of hospital visits, but also to enhance patient care and experience by collaborating together with the patient and family. So transfusion support. As I mentioned before, since the beginning of the year, my role has been focused on the hemoglobinopathy program, but specifically, I have been more involved with both pediatric and adult patients who require chronic blood transfusion therapy. Transfusion-dependent thalassemia patients do make up a majority of this caseload. However, there are a select number of adult and pediatric patients with sickle cell disease who are requiring ongoing transfusion support for various underlying reasons. I have been a consistent point of contact for these patients when they come to their transfusion visits, which has provided consistency in their care. We have also been working to coordinate their transfusion appointments on the same day as their follow-up visits in the hemoglobinopathy clinic to reduce additional visits where possible. Another relatively recent accomplishment within our pediatric hemoglobinopathy program is our ability to offer manual exchange transfusions. We have developed the knowledge and skill set to deliver this treatment to pediatric sickle cell patients for secondary stroke prevention or other specific circumstances. During the process of developing our manual exchange transfusion program, we collaborated with the Hospital for Sick Children and St. Justine Hospital in Montreal to develop our own protocol. We were then able to accept the care of a pediatric sickle cell patient with a history of stroke who requires manual exchange transfusions every 3 to 4 weeks. This patient's care was transferred from SickKids to our center, which has allowed this patient to get treatment closer to home and has reduced the amount of travel time for this family. As families are moving, we recognize as a tertiary center that patients are driving a distance, so we are also exploring other alternatives to provide follow-up care, such as utilizing community lab centers and community healthcare providers. Pediatric to adult transition. As mentioned previously, we have a joint adult and pediatric hemoglobinopathy program at McMaster Children's Hospital, which has given us a unique opportunity to enhance transition from pediatric to adult healthcare. We recognize that a well-encompassed transition process is a very important part of our sickle cell patients' journey to succeed in their transfer from pediatric to adult healthcare. We have the benefit of providing outpatient care in the same physical space. We also have healthcare providers, for example, the clinic nurse and social worker, who support both the pediatric and adult populations with sickle cell disease. This allows for some aspect of continuity of care and ease when transferred from the pediatric to adult hematologist. We do recognize that we need a better process for transition and by having a standardized approach. This means starting the transition process at an early age and having regular intervals where we can have dedicated time to focus on transition. We recognize that patients will have individualized needs, and we would like to better implement routine use of transition assessment tools to help guide this process. We want to optimize further our transition visits, where we have the pediatric and adult hematologist present to discuss patient goals and to enhance patient experience. We are also collaborating with community hematologists to provide ongoing care for patients with sickle cell disease who are going away to post-secondary education, which allows them to have support locally, but also to continue to have access to the resources and team at our tertiary center.
Okay, so as we continue to work on improving our care at McMaster Children's Hospital, it's important to really recognize how important the ongoing collaboration is of our partner organizations. So we're all here today because of SCAGO, and working with groups like SCAGO and the Thalassemia Foundation of Canada are really essential as we join together to advocate for better patient care. We also recognize many of our team members from McMaster who have built relationships over long periods of time with SCAGO and our other community partners, and they've served faithfully in many ways to help improve the care of sickle cell disease, and we continue to see those benefits. Our relationship with SCAGO has been especially instrumental over the last year as we have collectively been advocating with the Ministry of Health for more equitable funding for our program. And so this partnership is ongoing. As we mentioned, our team is small but mighty, but we definitely need more resource. And so we've been advocating with the ministry and SCAGO for that. So thank you so much to Lonray and SCAGO for your tireless efforts and your help with us on our team. So as we reflect back over the past couple of years, there definitely have been some improvements, and we're proud of the growth in our team. However, we really do want to acknowledge, and as we heard from our speakers previously, our patient and family advocates, we know that there is more work to do. So looking ahead to the future, one of our goals is to secure more permanent funding for our team expansion, and that should include not only for our current unfunded roles, but also for more broader roles that will allow us to provide the best patient care across the lifespan. Through this, we want to continue to enhance our pediatric to adult transition program, as Alyssa spoke to, and also improving the overall patient and family experience. And as the previous speakers shared, it's so important to have patient and family feedback as we look to improve together. And lastly, something that we're excited about at McMaster Children's Hospital and Hamilton Health Sciences overall is our integrated health network, or documentation medical records. Many people will know it as EPIC. They're calling it Odyssey at Hamilton Health Sciences, but this will be a more cohesive medical record, which we're hoping will improve many things for our patients, including the way that they get prescriptions, blood work ordering, reviewing lab results, appointments, test management, and having more access to their own health record through MyChart. So we're excited about that. And also for our adult patients, we know that this will be a much more connected system with our partners at St. Joseph's Hospital. So that's something also that we're looking forward to. So thank you so much for listening to Alyssa and I as we represent McMaster, and a huge thank you to SCAGO and the team for inviting us to participate today. Thank you.
Thank you so much, Alyssa and Krista. It's so interesting to hear about what's happening at other centers. I'm seeing questions that are coming into the chat right now. Please do keep them coming in the chat in the Q&A, and we'll be inviting our panelists to address those questions all together after our three sets of hospital representatives have presented. So next, I would like to introduce our speakers from North York General Hospital. And that includes Andrea Ennis, who is the clinical team manager of emergency department, Dr. Jocelyn Ma, who is a medicine physician, Susan Woolard, who's the VP of clinical services and the chief nurse executive, and Karen Fleming, the professional practice lead for nursing. So looking forward to hearing what's happening at North York General Hospital.
Great, and thank you very much, Dr. Bryan. I'd like to start this morning by thanking the organizing committee for inviting our team from North York General to be with you here today. I really want to acknowledge and thank the patients and families who shared their stories this morning, because they really do ground us in this very important work. This certainly has been a journey for us, and we look forward to learning from others from this summer. I just want to tell you a little bit about our team. It gives me pleasure to introduce them to you today, and it does span across our organization and across the professions. The journey for the patient often starts in the emergency department, as we've heard from our patients this morning, and thus the engagement from the emergency department is really key. Andrea has been the manager for many years, and her commitment to patient-centered care is really evident in all that she does every day. And unfortunately, she's just been called away to the department. So we'll try to pop on throughout the presentation, but is dealing with a situation right now. Dr. Ma is one of our medicine physicians who's really championing a lot of the work, and she works closely with her physician colleagues, but also the interprofessional teams on the care units as they're looking after sickle cell patients. Karen Fleming is new in her role as our professional practice leader, and she's been so instrumental in providing education across the hospital with our sickle cell committee and with the members listed to the right. And as you can see, it's an interprofessional team. And I'm Susan Willard, and I'm the Chief Nursing Executive and the Vice President of Clinical Services here at the hospital. And I have the pleasure of working with this amazing team. So again, I did say that it is a journey for our hospital, and so we'll start by sharing some of the work that we've done today and then some of our hopes for tomorrow. And I'm now going to turn it over to Karen, who will begin the presentation.
Thank you. Let me just get myself, oh, I am unmuted. Perfect. Thank you. I'm actually trying to, and I find this happens because I've got a dual screen, that the presentation doesn't show as nicely, but can people see the screen okay? Can I know if—
Karen, you're on the first slide, just so that you know, it's showing the improving sickle cell.
Perfect. And do we see the second slide now? There we go. Do we see the second slide now?
Yeah.
Wonderful. Do we now see the third slide? Just want to make sure everyone sees.
Yeah, we do.
Okay.
And so the next slide is yours. Thanks.
Lovely. Thank you, guys. Okay. So thank you, guys. I, too, am very excited to be here today. Being an advocate for sickle cell, I would say for over 30 years now. My mother had me involved since I was 12. And I am, anyways, we won't go there. And so it's really quite an honor to be here today and to be sitting actually on the presenter side of things. It is very exciting. So, and really excited to learn from our colleagues the different strategies they're doing and to share what we're doing as well. So at North York General, we do have a sickle cell working group that was initiated approximately 2 years ago, really looking at, we had an opportunity where we had admitted a sickle cell patient, and appreciating that there were barriers that they were experiencing in care. This working group was formed in order for us to focus in on how to improve the patient experience, our outcomes, and safety for patients diagnosed with sickle cell. So really wanted to align our approaches with the clinical handbook. So we did just actually spend probably, I'd say, the last, like over the summer for sure, but the last 5 to 6 months really looking at our order sets. So you'll hear more about that and aligning those with our clinical handbook, the clinical handbook for sickle cell disease. And our working group also really works on raising awareness about sickle cell amongst our healthcare team members. We promote education for staff. We like to look at ourselves as leaders for change overall while improving patient outcomes. And so some of the ways, we've done that is we've looked at the emergency and medicine order sets for adults and pediatrics. We've also created a care plan for sickle cell patients, so we'll get to take a peek at that. For Sickle Cell Month, it was great this year being able to really hone in and do different events each week. Well, for 3 weeks, we did different events. And so we had the fantastic Dr. Jacob Pendergrass speak at our medical rounds. And so it was wonderful to be able to invite him to just really give a strong talk on those patients diagnosed with sickle cell. The basics around pain management, yes, is one level, but really looking at how can we ensure that the care we provide doesn't create additional barriers, I found was a message that he shared throughout his presentation. We did a trivia roving cart, so we actually went from unit to unit with a roving cart because we know roving carts bring people. And so people spun the wheel, we asked them questions that were all related to sickle cell. And if you didn't know the answer, then we would say, okay, well, what do others think? And really generate some dialogue amongst the team. And I have to say that we actually had a roving cart in Emerge, I want to say 1 day, and about 2 days later, they had a patient with sickle cell, and they were able to really immediately notice some change for the actual care of the patient, and the patient themselves also commented because they'd been there before. So it was awesome. It was like exactly what you want. You know, you do the education and then there's that immediate uptake. And then we had a patient panel. So, I do want to thank some of those that are online. Gabriel, thank you. And I think Vitsan's online. If not today, she is tomorrow. I do thank you guys for joining our patient panel. And so we were able to invite 5 members of the SCAGO Patient Advisory and Advocacy Council Council, excuse me. And we invited them to join us at North York General to do something similar, to tell us, what are the areas where you find are repeated barriers for patients with sickle cell, and what are ways you feel that we could make a difference. So it was like an hour, like a lunch and learn, or really just a patient panel where we could listen in to our patient stories and start to formulate some thoughts about what changes we could make. And the primary MD and community paramedic program, that is something else that we are working on, and you'll hear more about that as we move through our presentation. And so now I'll hand it over to Jocelyn to speak about the order sets.
Thanks, Karen. I'm Jocelyn. I'm one of the hospitalist physicians at North York General Hospital. I was fortunate to be invited by Karen Fleming and also Norma McCormick to join the Sickle Cell Working Group to offer a physician perspective to the medical order sets. So one of the recommendations from the Ontario Clinical Handbook is to have order sets in place to guide clinicians on how to manage patients who are admitted with vaso-occlusive crises and to align the management to best practice. So I'm going to go over some of the changes that we made recently to the order set, as well as to the medicine admission order sets to better align our practices with the Ontario Clinical Handbook. So some of the main changes that we made to the ER order set were to default ibuprofen and Tylenol to being around the clock, but also to prioritize administering intravenous and subcutaneous opioids instead of having any oral opioids as initial options. We also adjusted the opioid dosing so that upfront we would be giving opioids either every 15 minutes or every 30 minutes for the first 3 doses, and then to have a physician or a clinician reassess pain until pain is more adequately controlled from the onset. We added some backup naloxone orders, and we also added some default orders to monitor pain scores, as well as some non-pharmacologic interventions that are known to be best practice for managing pain. And then we also made adjustments to the medicine admission adult order sets. So again, we defaulted ibuprofen and acetaminophen to be regularly given instead of only as needed. But I think the biggest change that we made was that we moved opioid analgesia above non-narcotic analgesia on the order set to try to make it a priority. We also changed all of the initial opioid orders to be either intravenous or subcutaneous again, along with backup naloxone orders. And then lastly, we also defaulted some of the best practices for care for nursing staff, including doing regular pain scores, non-pharmacologic interventions, management of constipation or bowel issues, adding incentive spirometry, and then also documenting intake and output.
And so I'll just touch on the pediatric order sets. And so very similar changes were made to both the emergency and the admission order sets for peds. And again, we did move the opioids above the non-opioids. We added a section for an opioid infusion. So that was definitely a big change. It was, we didn't even have a monograph for this. Hydromorph infusion is not something that we actually had even available at North York. And when I say available, I just mean we didn't have a monograph or a pharmacy directive to help support that. And so now we've been able to add this piece to help support the need for hydromorph infusion. Naloxone orders, really thought that was important because some of the feedback we get sometimes, having done a bit of a needs assessment with nurses, is their concern around overdosing their patients. And so, I have heard and, throughout the years and through the literature about the drug seeking and overdosing. But I do think that if you're administering a narcotic to a patient, you do want to monitor them for sedation. And so if I have a naloxone order to help me, should my patient become oversedated, my anxiety and my concern about oversedating my patient should be less, because I know I have something that I can access immediately should I need to access it. So I think that that's one way to address that particular piece, but most certainly there's more work to be done. We removed Benadryl. There was really advice in the clinical handbook around limiting the amount of sedatives you're giving the patient. So we did add ondansetron, and that is meant to still counteract some of the side effects. And certainly this is going to be our first go at making all these changes. And then if we find that a patient really feels that there's something that's beneficial to them from their perspective for their care, then we can always individualize their care plan and add those things back in. We also defaulted the consult to pediatrics in the emergency order set. So, I think that was a good decision for us to just ensure any patient with sickle cell who comes into emerge, there actually is a default to consult to peds. So then pediatrics will automatically get that consult and will come down to be able to help with the care required for a pediatric patient with sickle cell. Change frequency, and just to speak on that, I do feel like our pediatricians, having been the educator for peds just before this particular role, I do feel that the pediatricians, a number of them do come from SickKids, not to say that you have to come from SickKids, but a number of them do come from SickKids and have a comfort level with managing patients who need high doses of narcotic in a way that I do think if we compare our adult providers that there can be a bit more discomfort with that. So I just wanted to highlight that one of the pieces certainly is provider comfort. We changed the frequency of ibuprofen and Tylenol to around the clock. We, again, defaulted the orders for pain score, our non-pharmacological interventions, including incentive spirometry. Again, that came from the clinical guidelines to ensure patients have incentive spirometry ordered. And then the documentation field, right? Like we added the documentation field, like being complete. Don't just add the intervention and then nursing's going to be like, okay, well, where do I document? Ensuring that you add that piece too. So we made sure that we added a documentation field for that. Okay, so that's our order sets. The next thing that we're going to touch on is the care plan that we created. And so on the right-hand side, you'll see the template of the care plan that a provider can access when they're in PowerChart. So our documentation is Cerner. I heard Epic come up. So ours is Cerner. And so in Cerner, you're able to create care plans. And in this case, we wanted to not have the provider have to try to figure out what should I include in the care plan. Instead, we made this a bit of a guidance tool around best practices for any patient diagnosed with sickle cell. Again, this coming from the clinical handbook. And also we looked at there's another, we used more than one reference, but the major reference we did use here is the Ministry of Health Clinical Practice Guideline. And so the provider is able to initiate the care plan. The care plan must be initiated with 2 providers along with the patient at minimum. And then when it's initiated, it will now carry across the patient's chart. So if they get discharged and readmitted, the care plan will continue to carry across the chart. And anytime you update the care plan, the most up-to-date care plan is the one that will open. The most up-to-date one will be available on the chart. And when you open the chart, you are given an alert on the chart that the patient has a care plan. And so this is something new that will be triggering for patients with sickle cell. We do have care plans for other patients used a bit more periodically, not as structured, I don't think, as we are trying to do for sickle cell. Like sickle cell is the only one we have an actual template, which really guides and highlights things. Because if we help provide that information and knowledge, then the comfort level to me will increase because you feel reassured with your decisions. And if they're admitted within 2 years, right? The alert comes up, and then there's an order as well for nursing. There's an order that'll tell you to review the care plan. Okay, so that's what we have done from that perspective. When it comes to education, we've done a few things. The emergency department has their own actual nursing orientation on sickle cell. That was great to hear and to learn about. It has been live, I want to say, for about the last year. And so any nurse coming into the emergency department, you'll see the topics there. The topics, those are the topics that are covered by one of the emergency nurses who I feel like from an advocacy, I'm just so excited, from an advocacy perspective, wanted to take on this opportunity to help inform her colleagues around sickle cell and to be able to lead that education. And so that education is happening. And then across the organization, we're going to be, this is something that's actually coming up in this month. After we did our, sickle cell month, we were able to do education through our trivia card. The follow-up to this is how do we now keep nurses informed? And so The RNAO does have a sickle cell, what every nurse should know, set of slides, which I honestly feel like if you're talking basics, you just want something for corporate orientation, for your hospital, that these slides are perfect from my perspective. You can check yourself and see, but they have slides and they also have a video. So in case you actually want to see the presentation and hear some of the questions, you'd be able to catch that in the video. So you can find that on the Registered Nurses Association of Ontario website. And then from a medical perspective as well, I am working with the docs right now just to clarify, how are we really going to roll out the education for the order sets? Having the order sets alone is only one step. We need to ensure the providers know that they're there. That we'll be doing some auditing of the use of order sets, that we'll be following up, around how many patients get admitted, how many times is the order set triggered, how long did it take us to give that first dose of narcotic, etc. So we're going to be working on that. And so one of the final pieces around education that I'd like to share is a virtual simulation game. I'm in the final steps of actually completing this game. It's really meant for nursing students and also for like brand new nurses to emerge. So I picture this as being something as pre-work to the 1-hour class they would have in their emergency orientation, nursing orientation around sickle cell. And so it allows you to be presented with various scenarios that the nurse is meant to critically decide what is the best decision I should make in this moment for my patient. And then they're shown a vignette. So they're shown a video about, so they see a little scene, they're given a question, and then they'll see a scene after that, dependent on whether they answer the question right or incorrectly. And if they answer the question incorrectly, they actually can't move forward until they answer it correctly. So it's to reinforce learning. And so very excited to have been able to work with CanSim and also with my school to produce this virtual simulation game. It will be available, I would say, through CanSim, but you can always reach out to me if you want more info. It's the first of its kind. Like, I'm a bit, almost teary-eyed about it. It, I think, is amazing. I'm just excited at the ways we can help healthcare providers learn about sickle cell in a way that they can do it on their own. You can do this, I can just do it on my own. And for the biases and things that come up and get uncovered within the game, I can reflect on that on my own and make my changes and come back to practice and have the right practices reinforced. So that's the idea behind that. Our patient and family advisors, just so you know, we do have this role at the organization, along with, I'm sure, most of our organizations have some sort of patient and family advisor committee. And so again, we've connected with them to see if there's a way we can incorporate patients with sickle cell onto as a PFA. Like, can we directly just ask a patient with sickle cell, would you like to be a PFA, a patient and family advisor? And so I was able to forward out that package to a few patients. And so just waiting to hear back, but hopefully being able to incorporate patients with sickle cell onto our committees, into our sickle cell working group, onto our anti-Black racism committee will help us to, again, reduce the barriers and inequities they face. Okay, so this is back to Jocelyn.
Thanks, Karen. So I think recently we've started to work with the Quality Improvement Department at North York because we wanted to actually better quantify the magnitude of the issue that we're facing with right now, and also try to set metrics to better understand the current state of our patient care for individuals with sickle cell disease, as well as set targets for what we want to improve. So we were using standard metrics that were actually outlined in the Ontario Clinical Handbook, such as the length of stay for patients, percentage of patients who are readmitted after presenting to the emergency department or after being discharged from hospital within 14 and 30 days after discharge. We also use metrics such as the time from initial presentation to the emergency department to the time of the first dose of receiving opioid analgesia. So the hope is that we'll be able to track these metrics after we introduce these quality improvement projects, after we introduce the order sets, the virtual simulation, all of the educational interventions that Karen had mentioned, in order to better quantify, if patient care has improved, and also to identify some of the biggest gaps that we're also facing. And sort of our long-term goals are also to be able to compare those with some other hospitals using some sort of shared data that we have with other hospitals. So our main goals were to decrease the time from a patient's presentation to the ER to receiving their first dose of opioid analgesia by 10%, and to reduce the rate of representation to the ER within 30 days of discharge from hospital by 10%. So here are some of the baseline metrics that we've collected so far from the 2018 and 2019 fiscal year. We didn't collect data from the 2019-2020 fiscal year because that year was felt to be an outlier due to the COVID pandemic, and we know that our ER volumes in particular were quite low. And we also haven't been able to present the average time from ER presentation to first dose of analgesia just yet, because we're still trying to figure out with the information services team how to actually accurately collect that information from Cerner, but we're working on that, and hopefully we'll have that information in the next month. So you can see here that on average in 2018 and 2019, the length of stay was 8.7 days, with 34 admissions in total in 2018-2019, so really not insignificant. So we're hoping to compare this length of stay to other external facilities, and we're working on collecting that data right now. This slide also outlines the number of patients who presented to our emergency department with a vaso-occlusive crisis within 14 days and within 30 days of their last presentation to the ER. We know that representation is often an indication that perhaps their pain was suboptimally controlled. So our goal is to reduce this rate by 10% as well. So the absolute number in 2018-2019 was 29% of all presentations for sickle cell for vaso-occlusive crisis in that fiscal year.
I'm so sorry, Dr. Ma, you only have about 1 minute left.
Yep.
So
That's our last slide.
Mindful of the time. Thank you.
All righty, and I'll be brief. And I started earlier this morning and said that the patient journey often starts in the emergency department. But when we think about it, our community colleagues are just as important. And so what we're trying to do is work with our primary care physicians so that we can ensure that sickle cell patients have access to primary care, and that we can work with primary care physicians so that they get the enhanced knowledge that they need, and we can work together on the evolving best practices. And then, of course, working with our EMS partners to ensure that our patients get to their primary hospitals and their the hospitals that know their care best, so that it helps to provide that continuity of care. And then within the hospital, we can have personalized care plans, which will then, of course, help our patients to get the medication and other treatments that they need in a very, very timely manner. So on behalf of our team today, I want to thank you for the opportunity in participating in this summit. And we've got Karen's contact information, and we'd be happy to work with others. Thank you.
We thank you so much, Susan, and your team at North York General. You're doing amazing work. I'm very fascinated and impressed by the simulation game and stuff like that. Those are innovative and would surely help to transform, the quality of care to sickle cell patients. So thank you so much for that. For this section, we will invite our last presenter, Dr. Raheem Vallahani from William Osler Health System in Brampton. He's an emergency physician, and we're very proud to have him with us today. We're very pleased. Thank you, Dr. Vallahani. Are you there, Dr. Raheem?
There we go. Sorry, I needed to find out how to unmute. Can you see my slide there?
Yes, it's on. Thank you.
Perfect. Thank you so much. So thank you all very much for inviting me here today. Sorry about the 30-second technical glitch there. Before I begin, I just wanted to thank the panel, first of all, for inviting me here to present. But first and foremost, I wanted to thank all the patients that are people with sickle cell that have come here and shared their stories, because I think that narrative is very strong and empowering for us to understand what is going on and for us to understand how we need to change and get better. I'm a physician. I work as an emergency physician. I first came across or started becoming more comfortable with sickle cell patients and understanding the disease process itself when I was taking on my training at SickKids, which sees a lot of sickle cell patients. And, going through the journey and understanding how we treat these patients, what the complications are, it became an interest of mine. And to understand what barriers we have in terms of why are we not having the appropriate treatment for them out in the community or centers that don't see as many sickle cell patients. I also undertook a few research projects in the area, and I'm continuing to do that to help understand how we can continue to improve on this. So I apologize, I might turn my head this way because I'm working with two screens over here, so bear with me as well, please. As I start, I'm going to start with a narrative again, with the story of an 18-year-old patient. He was a male patient that presented to our emergency department, and he had come in complaining of chest pain. He had informed, right at the start that, I've got sickle cell disease, and I'd like to be assessed by, in the hospital and get treated for it. Unfortunately, he got triaged as a C-test level 3 when he came in, is the first thing. And, he had waited probably close to 3 hours before he was seen by the emergency physician, which was myself. And as soon as I had seen the chart there, I was like, wow, okay, let's run on this. Let's get this going. We got to make sure we manage this right. Could this be a potential chest crisis? What's going on? And even though we had already established order sets at our institution, not everybody knew about this. So the patient was very grateful that I had seen them, and we started the treatment right away. But the question remains is, what are the barriers that we currently have in place? And so I'm going to talk about, how we can continue to improve. We've come up with great narratives in terms of this is what our institution is doing, this is what's going on. But there are still major strides we need to take to move forward. So first and foremost is going to be education. Education not only of physicians, but also of nurses, of all the healthcare professionals that are associated that can come into contact with a patient with sickle cell disease. So from our end, we introduced education for the nurses, and we continue to reinforce that. And I think that's continuing to ongo at other institutions as well. My predecessors at North York are certainly using that as an introduction for new hires and new graduates as well, which is amazing because people need to be aware of this. Education for physicians. So we continued with rounds for the physicians, where I presented for the group in terms of the emerge part. We had an adult hematologist as well as a pediatrician, both of who are very comfortable with managing sickle cell patients. And we talked about what the order sets should entail, what they should include. We've talked about barriers in terms of providing appropriate analgesia. And for me, it's very important to ensure that the patient gets, the fluid management, the opioid management, and making sure we're not running into other complications like a chest crisis as well. So it's not only managing vaso-occlusive crisis or a chest crisis, but all other complications that can arise as part of having the disease, and knowing how to manage it and also look for these things in the first place. We also developed order sets, and we went through a bunch of iterations. Initially, it was like, should we be allowing hydromorphine infusions? Well, the pediatric group wasn't comfortable with that because most of people tend to use morphine infusions in the pediatric population. But working together collaboratively as a sickle cell working group with an emergency physician, nurse educators, nurses from the ward, nurses from the emerge department, the sickle cell working group, as I mentioned. And what we came up with was a fairly robust set of practices, starting from what blood work is necessary, because there are things that get missed. People might not do, for example, a reticulocyte count. Knowing what opioids to use and what the dosing is, because either you're tending to underdose for them with the hope of getting away with it, or not knowing how to start opioid infusions on them. So we had all that put into place so that it became almost like a no-brainer for the clinician to be able to say, check, this is what I want, and this is how we're going to proceed with it. Then came, adjunct therapy. So for example, heat or ice or whatever that works best for that patient. In my particular situation with that patient with the chest crisis, I asked for incentive spirometry right away, and it's not in our order sets. And everyone looked at me as like, we don't carry that in the emergency department. I'm like, but it's been shown to be beneficial for these patients. So can we get some downstairs? And we were able to then assimilate that as well. And then carrying on those order sets for the inpatient, right? And making sure that the team that is admitting the patient is aware of what the patient is presenting with, how we can monitor them, and continue with best practices to ensure that we're optimizing their care. The next thing is evaluation of the process itself. Now, we started the order sets probably pre-COVID, and I'm sure with every institution, there's been sort of glitches and breaks in terms of trying to get things forward, and not surprisingly, the same at our institution as well. And so we haven't had a good chance to actually evaluate our order sets. We've certainly used them. We've had some great feedback from the clinicians and some of the patients. But what we need to do is do a robust evaluation, and some of the metrics that, these other institutions have brought up, I think it's important for us to collaborate on this to understand how we can learn from each other as well. And then understanding the update on the evidence itself. Are there new things that are up and coming? Are there things that we can improve upon? And a shared group such as SCAGO is obviously a great model for us to help share in this, such as this conference, and how we can build on this. So I've touched upon some fairly high-level points over here in terms of how we can improve on this. And I'm happy to share this during the Q&A. I don't want to take up too much time sort of going to the granular, what our order sets are, what exactly each line item is. But I think a lot of the richness of this will come from the discussion, the questions that will come around from this. So I'm going to stop at this point and say happy to take questions and learn from the team.
Fantastic. Thank you so much, Dr. Vallahani. Raheem, it's good to see you.
Thanks, Jennifer.
Yes. Thank you to all of our presenters in this section. I've been furiously taking notes as you've all been speaking. Fantastic ideas. I would invite all of our speakers for this, this section of today to turn on your video. And at this point, we can move into our Q&A. So this is a great opportunity to ask any questions that you might have of any of the speakers about the work that they've been doing. I see that we have a few questions in the chat already, which is wonderful. Please do keep them coming. We can start off maybe with a question that was for our McMaster group. So there's a question in the chat, a very specific question about the exchange transfusion approach, and so about the manual exchange, and asking if this is via apheresis and if you're checking for iron overload. So Alyssa and Krista, are you able to speak to that question?
Yep, I don't mind speaking to that question. So in terms of the first question with the apheresis, we don't have that at our center for pediatric patients right now. It's just the manual exchange transfusions where you're manually phlebotomizing. And then in terms of the second question, in terms of iron overload, as many of you already probably know, manual exchange transfusions reduces or slows the accumulation of iron compared to simple transfusions. So that's one benefit of the manual exchange transfusions. And typically we monitor their ferritin levels. And if we see their ferritin trending upwards, then that would kind of determine at what point we would decide to proceed with a ferroscan, which is an MRI test that will give us a liver iron concentration and more reliably give us an estimate of total iron overload. But that's typically what we would do. And we only have one patient right now that in our center that or pediatric patient that is receiving manual exchange transfusions at this point. So we're still very early in the development.
All right, thank you so much for that. Hopefully that addresses the participant's question. Again, feel free to put any other questions in the chat or any follow-up clarifications that you'd like to hear. Ms. Lannery, do you want to take us to our next question?
Yes, so the next question is again, I believe it's meant for the McMaster. What are the biggest challenges, struggles that your patient experience when they transition from pediatric to adult care?
Can I answer that one as well, Alyssa?
Yeah, I can kind of give my personal opinion. I think we could probably do a more formal evaluation to find out from patients directly what the struggles are. The one thing that comes to mind is going to the emergency department. So as pediatric patients, they're very accustomed to coming to McMaster Children's Center or McMaster Children's Hospital for urgent care. And then all of a sudden, they can no longer come to McMaster Children's Hospital and they have to go to St. Joe's Hospital. So I think that's definitely a challenge, and for patients when they're transitioning from pediatric to adult care, and just the whole inpatient experience would obviously be unfamiliar to them as well, being so used to McMaster Children's Hospital. So that's one thing I can think of. And then the other would be just advocating for themselves. I think in the pediatric world, we advocate for our patients a lot, and their parents advocate for them, but I think there's more onus on the patient once they're in adult care to advocate for themselves. So that would be the other thing I think would be a challenge in terms of transition.
Thank you very much, Alyssa. And before I hand it over to Dr. Brian to ask the last few questions in this segment, I wanted to recognize the presence of Karen Nero and Rodaya Valhubeshi, both from Ministry of Health. Thank you so much again for joining us. And by being part of this, you are at the table listening to the needs of the hospitals, listening to the patients and the needs, and also how the hospitals are responding, and what else will make the hospitals to even function better in order to provide that high standard of care that sickle cell disease does require. So I just want to pop in there and just to thank you for being part of, the summit today. And on that note, I hand it over to Dr. Brian. Thank you.
Thank you. One of the questions that popped up in the chat, I think was specific for the North York General Hospital team, but it can apply to all of the groups here today, and certainly is a question that hospitals across the province and the country are dealing with, about emergency department wait times. So I wonder if each of our groups can speak a little bit to what you're trying to do to address emergency department wait times for your patients who are living with sickle cell. And maybe we can start off with Dr. Vallahani
Sure.
from William Osler. Mm-hmm.
Thank you, Jennifer. For those of you who may not know, William Osler is Brampton Civic is a fairly busy emergency department. You've seen close to, lately we've been seeing close to 450 patients a day, right? So you look at a volume of about 150,000 patients a year, which is probably the busiest ED in Ontario and probably in the top 5 in Canada at this point. It's always a challenge because, we've got several bottlenecks starting from registration and triage. We try our best to get the patients in as soon as possible. And the goal is to have these patients categorized as a CTAS too. So again, CTAS is an acuity scale, 1 being acute resuscitation trauma patients, 2 being fairly sick patients. The guidelines are to have CTAS 2 patients, the Canadian guidelines to have CTAS 2 patients seen within 15 minutes of arrival. I'll tell you, I don't know very few emerges can actually pull that off, I'd probably say. Number 2, as I said, we've got a fairly robust triage and screening process. So by the time they're triaged on a very busy day, that can be about an hour or 2 just to be triaged at our center. So that's a major impact right there. Third, we actually looked at, the third piece is all these patients are categorized as a CTAS 2 patient, unless they've come in with some other element that's not related to the sickle cell disease complication. So if they've come in with either a chest crisis or a vaso-occlusive crisis, we triage them at the highest level possible, less a resuscitation unless they've come in with abnormal vital signs. We did a study of about 500,000 patients looking at patients coming to the emergency department. What we found is for CTAS-2 patients, we're only meeting that 15-minute target probably 40% of the time, at most 50% of the time. So there are system changes that are needed for us to actually improve on that time. But I think the first thing is recognizing that sickle cell patients deserve, access to better care and to be up triaged and not put down at the 4 or 5 level, even though they may be looking good in front of you. That pain crisis has to be managed, that has to be treated so that we can really work fast on them, because there are complications associated. Gabriel had mentioned the AVN. We know studies after studies have shown the more recurrent crises you get, the more osteonecrosis risk factors increases. So I think just having a system in place where you can get them up triaged, and then from a global perspective is having systems so that these we can actually see patients quicker through the emergency department. Thank you.
Thank you, Dr. Vallahani. And great to hear the clinical handbook coming up again and again in our discussion. We're going to be hearing even more about that from Dr. Berhovsek this afternoon. So looking forward to that as well. Could we hear maybe from North York? So Susan, Karen, Jocelyn, about what's happening to try to decrease the wait times for people who are living with sickle cell who present to your hospital.
Maybe I can just start off and build on what Dr. Vallahani has talked about, in that ED overcrowding is a system issue, and not specifically related to the emerge, but sort of the hospital and then beyond in the system. And so it's a very complex problem. And I guess one of the things that we've tried to do at the hospital over the last, I'm going to say 10 years, is we have an access to care committee at the hospital at a corporate level to try to keep the whole hospital moving. And so to try to decongest the emergency department so that our sickle cell patients, when they arrive, will have timely access to care. And like Dr. Vallahani, they will be triaged as a CTAS-2. And I think that that's very helpful to have that standardized plan of care. And then beyond that, to have the personalized care plans that we can have for our patients. So we know exactly what to order for the patient, and whatever treatment they require, we're not starting from square one. And so I think that the electronic order sets are also going to be key in helping us to provide that timely access to care. So maybe I'll just stop there and just sort of building on what Dr. Vallahani had said.
And the only other piece I would like to add on to Susan's piece is that there is a way.
Thank you very much, Susan, for that. Can we ask everyone to kindly mute them? Yes, thank you. Thank you. I think Linda raised her hand. Dr. Jennifer?
I think Karen was talking, but your microphone was up, Karen, so we couldn't really hear you. That's why, yeah.
I was wondering why Lanry cut me off. We're such good friends, Lanry.
I'm so sorry. I didn't realize that you were speaking. Sorry about that.
I was the person. I was the culprit. I'm sorry. My speaker was up. I'm sorry.
No worries. So go ahead. Thank you, Carrie.
I just wanted to add a little piece to Susan's piece. In speaking with one of our quality improvement specialists, because I don't know actually that we chatted, we did talk about the data collection and that we do have quality improvement specialists helping us. And one of them is a previous emerge nurse. And so she's able to tell us some details like, how can we get the swipe nurse to help the patient, jump over the triage nurse. And so this is one way that we're just discussing. It's something that would just have to be kind of, something that's in our plan, that when the patient arrives to the swipe nurse, that they then get bumped beyond the triage nurse, right to registration. So that would be, to me, one way we would really be trying to reduce that wait time. But again, echoing what Susan had said, it's a big problem regardless. Mm-hmm.
And I think I would just add to what both Karen and Susan have said, is that one of the targets that we're looking at too with our quality improvement project is not only improving the wait time, but really the time from presentation to ER to the first dose of opioid medication, or the first time that they actually start getting treatment. I know the Ontario Clinical Handbook is actually recommending a 30-minute wait time from presentation to the emergency department. from when they first walk into the door to when they get the first dose of analgesia, which I think is a pretty ambitious target, but that's, we're sort of working hopefully towards that. But at least for now, our goal is to try to reduce that time by 10%.
So I'm just sorry. Thank you, Jocelyn, for that. But I was just going to add here, I actually did an audit during my fellowship on this. The median time for opioid analgesia, IV opioid analgesia, 5 hours. And to antibiotics is about 3. So certainly there's a lot of ways we can improve. And I think the order sets are going to help improve that, because as soon as you check those off, hopefully we can get those implemented rather than waiting for the patient to come and manually writing the orders and getting through and missing stuff. So it's certainly an area of market improvement that we can work on.
I agree. I'll say, we had some preliminary data that was suggesting that our hospital, it was 4.8 hours, but we were looking into whether or not that was accurate. So we just didn't present that today just because we're still looking into whether it's correct or not.
The last question I would love for us to address at some point, this is actually for all hospitals, is anyone using medical directives? I'm interested in that piece. I haven't heard it mentioned yet. It would be really nice to hear about that.
I can just speak from McMaster. I don't believe, I used to work in the emerge, and so did Raheem. Hi, Raheem. So we don't have medical directives specifically for sickle cell. However, just as a nurse, I can say that the order sets definitely help in a huge way to almost drive like a medical directive, because what happens is we immediately, the second that a patient with sickle cell in pain crisis is triaged, as a nurse, I'd be pulling that order set up and anticipating what the needs are. And so oftentimes, even before the patient's even in the room, I'll have the order set printed, I'll have the blood work labels drawn, and even go to the physician and say, we're going to start this. So yeah, we don't have something specific that says go do it without the physician assessment. But certainly that order set is a huge trigger to anticipate what the needs are and get going before, before we're waiting for a full assessment.
So Karen, just to your order set medical directives piece, again, this wasn't at Osler, but previous institution I worked at, because we were seeing a lot of sickle cell patients, we allowed the first dose of the opioid to be given right at triage, or like as soon as possible, basically, as a medical directive. So that could help bridge the time by the time the physician sees them and everything.
Thank you. And sorry, which center was that? Sorry, I didn't hear what you said, just so if I wanted to see it. Are you able to share, or you want to secretly email me separately?
We can go offline.
Yeah. Okay.
Yeah,
Thanks.
And I have a question for any of the hospitals. What would be your, we have suggested to the Ministry of Health to ensure that every hospital has a sort of a poster in the emergency department to kind of remind care providers on sickle cell care, like, this needs to be done by this time and followed by this and this and that. Some sort of directives, whatever, but in a poster, simple form. I just want your opinion. Any of the presenters can speak to this. Do you think that will really help to have something like that, in your emergency departments? Would that improve on the care?
I can start with that if you like. One of the things you have to realize is a lot of sickle cell patients, at least this is something that I looked at a few years back, tend to congregate around centers that have sickle cell experiences. Okay. Now that's not to say they don't live out in different areas, but they'll either try to come back to that center for their care, or they're congregated around this because they know that these centers are aware of what sickle cell is all about, or should be anyway. The poster idea is not a bad idea, but one thing that would be really grateful is having appropriate care plans, especially for patients that are not in larger cities or towns, because it is more in the rural practice where, the emerge doc there is seeing this patient once every 3 years that doesn't know how to manage them. And so having that care plan attached to them or having it with them is really, really helpful. So some sort of either as a central repository or that the patient can carry with them will help enable and educate that doctor. Hemophiliacs do that. They carry their hemophilia chart. If they're going out in the cottage country, they'll take their hemophilia chart with them tell the patient, this is what I want, recombinant factor 7. Why can we not do that for sickle cell patients as well? I think that would be a really good way to actually push this forward, the agenda forward.
Definitely, Dr. Vallahani, you made a good point. Having individual care plan and the patient having access to that, I think, is very important. I'd like McMaster to also comment on the idea of the poster, in addition to, of course, care plans and other sets and stuff like that. Just to remind, because what we find also is that sometimes it depends on who is on duty. You may go to the hospital one day and you get good care, and then you go back the next time, and this person is not very familiar. And if there's no other set, and they may be, but just something to maybe remind you. What do you think, and how do you think that will help improve the quality of care you're providing in your hospital? McMaster.
Yeah, I think any ideas are helpful. I think the only thing that I worry about, and I don't think you're saying this, is that we can't rely only on that, because there's just so many signs, especially with COVID. We just see signs everywhere. And so a lot of our staff talk about sign fatigue. And so my only worry is that someone might put that up and think, oh, we're good. And so really it would have to be in combination. I think, Lonray, it's a good idea even to empower patients, if they're not receiving great care, to be able to say, look at this poster. That could be something that they could, draw to really identify and say, like, look. But certainly I think we would all agree that just really big advocates for the education that needs to go into supporting all these initiatives. We can do order sets and posters, but without people really understanding and having that education, I think it falls short. And then I also just want to give a plug for the outpatient side, just to really say that I think a lot of this starts with really great care in the outpatient setting. And the hope is that we can actually avoid and reduce emergent visits. And so I think that's why from an outpatient perspective, we're advocating so much for resource to also go there, because if we can help solve a lot of these issues before we ever get to an emerge, I think that would be an even bigger win.
You're definitely correct, Krista. We definitely need to reduce the number of emergency departments visits, and that would be if we have a robust, comprehensive plan for the patient. And I will pass the last word to North York General on their thought on having a poster as an additional resource to support. I like how Krista pointed out it could be a source of advocacy for a patient that's facing a difficult time in accessing care. I know Dr. Vallahani mentioned that many of the patients goes to centers of excellence that have sickle cell programs, but what we really want is, no matter where you are in the province, you should have access to equitable care. Well, and I agree, it has to be a multiple of things, not just one thing. But would North York think that the poster could be any additional help at all?
Yeah, so I agree with both points. I hear what Chris is saying too, the sign fatigue, because I think even about emerge, there's so many things, and with such a big department, would you put a sign up in every zone? Like, where would you, I guess it would be a bit of a conversation around where is the best place to put it, where would have the highest impact in those moments. And I also agree that around patients with sickle cell tend to, we heard it from Gabriel, going to organizations that tend to have higher familiarity with patients diagnosed with sickle cell. But I do feel that that's even a bigger reason why we do need some reminders, and especially like in a community setting like ours, where we see them not as frequently as a bigger center, but we see them. So just to remind people, because the care is so unique, it's so comprehensive in nature, that we want to ensure that it's triggered correctly up front. So that would be my feedback. I don't know if Susan has something to add too.
No, I would absolutely agree that, there is fatigue right now across the healthcare system overall. And there are a lot of signs about COVID and so many other things that are on the walls. I think, to me, the ongoing education so that people understand it, and it's built right into the sort of pathway that the patient has. And I would say not even just in the emergency department, but up on the inpatient units as well, is absolutely key. So I think it's something that we need to strive to sort of keep as a pathway and an education and a highlight for all of our teams, and maybe just a bit of both. And we can think about where a poster might be helpful, but recognizing that, you know, there is a lot going on in the system right now. And, you know, people are, I think there's been so many memos and everything over the last year that it just may be noise on the walls versus a trigger on the wall. So, you know, just to sort of think about both aspects of it.
Thank you very much. Thank you. I'll hand it over now to Dr. Brian.
Thank you so much, Lanray. I am loving this conversation. I'm loving that there's so much communication between the three groups who presented today. The hope for these next couple of days is that we have a chance to all learn from each other. So that's exactly, I think, what's happening here. And on that theme, I wonder about some of the great ideas that we've been hearing about this morning, about ways that we might be able to share those between our many different centers. So thinking of the example from North York around that simulation exercise and the gamification of learning about sickle cell, that would be a fantastic thing to be able to bring to other centers. Is that something that you've started doing yet? Are you talking with other centers about sharing some of those exercises?
So because the game doesn't belong to me, I'd have to have a bit of I'd have to see how it works exactly. So I did it through the Canadian Association of Nurse Educators in Simulation, so CANSIM. And I also did it as a part of my Master's of Science in Healthcare Simulation. This is my capstone project, was to create, I picked directly, I was very deliberate in what I chose. I wanted to do sickle cell. I wanted to do a patient arriving in the emergency department. And I wanted to show all of the various myths and barriers that we read about and hear about on a consistent basis. It's in your face in this game, so that we can just really acknowledge that we all have biases. We all have biases. That's just a fact. But we want to ensure those biases don't impact the care we provide. I'd have to ask. I know North York. I know I can use it at North York because I'm a North York employee. I'd have to ask, how can I share it with others? That's what I'd have to find out, but I'm happy to ask because I certainly would love to share it. And if not, I'm happy to work with others around how did you create it? Oh, certainly, you know, I could help guide people because simulation certainly is one of my expertise that I love talking about.
Fantastic. So maybe that's something that you can communicate directly with Lanray about. And then if participants are interested in finding out more, they can reach out. Excellent. All right. I also would love to hear a little bit more about the role of the healthcare aide that Alyssa and Krista were talking about. So your description of Iola offering support for things like reminders about appointments and those kinds of things that can do just what we were talking about earlier, maybe decrease the need for those emergency department visits when the connections with clinical care are strong. So Krista and Alyssa, are you able to speak a little bit more about that role within your team?
Sure. I can start, and then Alyssa, if you have anything to add. So really this role, as I mentioned, Aola's full-time role is actually on our inpatient unit. But when we continue to look at our clinic and just feeling like there's really need for support, we asked Aola if she'd be interested and willing in helping and come over onto the outpatient area for the clinic days. And so she very enthusiastically was happy to take that on. And so what she does is part of our role, because we have the adult and pediatric clinic, and we just have one RN who doesn't even work full time. She's pretty amazing, but again, we need more resource there. But what we found is there an opportunity to have someone help with even just the rooming of patients, bringing them into spaces, having somebody that's a friendly face. If there's a bit of a wait time, having someone that at least chats with you and talks with you and builds some rapport. And so Aola's really exceptional at doing that. She'll bring people into the room. She'll, chat with them. If they have any immediate concerns, she'll be able to share those with the team. And then for the reminder calls, what we found is that we were having a lot of no-shows, and that often is, I think, related to just the time period between an appointment and then the next appointment. We also know that a lot of our hospital systems are very archaic, and so people get mailed letters about appointments sometimes. And we wish we had better systems with text reminders and things like that. And we're hopeful that we might get more of that with our new medical record. But as of right now, a lot of it is really reliant on paper, fax, mail. And so what we found is that having somebody call and do a reminder a little bit closer to the appointment makes a difference. We know that it's hard to book into appointments because our clinic is so full, and that there's just not enough resources to have clinic every day. And so if someone misses one appointment, that can have a huge impact if then we're not able to book them again for a long time. And so I think we're seeing the benefit of AYOLA's role just in trying to help make sure people are aware of when their appointment is, where to go, and be able to answer questions. So yeah, anything else that you want to add, Alyssa?
No, I think you covered it all, but yeah, we have, since she's been involved, we have noticed the number of no-shows has significantly declined. So that's been really helpful, and just helping with the flow of the clinic has been instrumental as well.
Excellent. So it sounds like you've really got some objective data about the impact of her role. Would be great to have opportunities to share that with other groups. Could help to advocate for funding for similar roles in other groups. Okay, that's wonderful. Ms. Lamry, I wonder, do we have time for one last question? Can I ask one last question?
Yes, we do.
Awesome.
Thank you.
All right. I wanted to follow up also about the care plan that was discussed by the North York group. So lots of interest from patients about having individualized care. And so recognition when they're coming into the hospital to say, this is the dose and the medication that works well for me. Can you tell us a little bit more about that care plan? And is it more of an individualized order set as opposed to kind of being standard order or standing orders?
Yeah, so it is different than being standing orders. The standing orders that are part of the order set would really be based on the guidelines, for a patient who that really fits, the doses that are there. They kind of follow that their needs are met by what the order set actually has embedded in it. Then they may not need this individualized care plan because they don't need something that kind of goes outside of what we already have available, or perhaps they need Hydromorph, for example, as opposed to morphine. So then, yes, we can activate this care plan, and there's a bit of discussion. We really right now want to start off with activating a care plan for all patients with sickle cell, as opposed to actually saying only do it for those that are outside of the exception, because then there's decision, it's subjective in nature. So we really actually want to say anyone who comes in with sickle cell needs a care plan. Even if it's the exact same as the order set, you need to initiate something so that we have that ongoing use of care plans to help support the individualized care for that patient population. So yeah, you can fill it. It's basically a blank space that you can denote different headings and put in it what you'd like, but people won't be as inspired to do that unless they could copy paste and just erase stuff. So that's why we've templated it out that you can actually just copy exactly what we have, paste it into your blank space, and then you can adjust it for your particular patient. So trying to really make it easy for the user was one of our goals. Did anyone have any other questions about the care plan? It's a new thing for sure. I like that it updates. I like that it goes across counters. It's a lot of work you got to do with your informatics team, right, to see what are the possibilities, and if those possibilities exist, how can we apply it to a patient population that really tends to experience a number of inequities. So it was great. So our IS team, there's so many members that participate in this work. And for the virtual sim game, I do want to thank Fitzanne. She was the patient, and she's a part of SCAGO